Welcome to everyone attending the webinar from around the world today. Today we'll be talking about a spotlight on rare and complex epilepsies, nursing considerations and educational needs. My name is Melissa. I'm an epilepsy nurse from Sydney, Australia, and I'm going to be co-moderating this session with Nancy Santilli, who is an epilepsy nurse practitioner. And I would like to welcome everybody. Just a quick update on membership. More than 860 nurses across 6 regions, and we're growing. So please join the ILE nurses section if you haven't already. You can visit the website that's on the screen, or you could use the QR codes both in English and Spanish. And we can grow our group to a bigger and more successful group. So the purpose of today's presentation is to recognize the family's experience living with rare and complex epilepsy disorders, tailoring nursing strategies to address comorbidities affecting people with rare epilepsy syndromes or complex epilepsy, and describe ways that nursing education may incorporate issues unique to people with rare and complex epilepsies. Our agenda, we have 3 great speakers. The first speaker is going to be the lived experience, the rare epilepsies, and it's going to be Conecker, who is the Executive Director and Co-Founder of Decoding Developmental Epilepsies, and she's from the United States. The second speaker is a nurse-led epilepsy service and Australian experience, which is completed by Brialie Forster. She's the Developmental and Epileptic Encephalopathies Clinical Nurse Consultant from the Austin Health in Melbourne, Australia. And then the third speaker is going to be talking about education, so European Reference Network, or ERN EpiCARE, rare and complex epilepsies, creating a dedicated working group for nurses. And Nicola Lawrence will be talking about this, and she is the project manager and chair of EpiCARE Nurses Working Group, and she's based in London, the United Kingdom.
Hi. My name is Conecker, and it's a pleasure to be with you here today for this epilepsy educational webinar for the ILE nursing section. I'm honored to be able to connect with you and chat with you today about the rare and complex epilepsies from the point of view of both a mother and a patient advocacy group leader. As you can see here, I'm the executive director and co-founder of Decoding Developmental Epilepsies, which runs both a disease-specific organization for a group called SCN8A Alliance, as well as some cross-DEE or rare epilepsy projects. I want to start by, first of all, thanking all of you. You are incredible. I hope you recognize the role that nurses play in the lives of rare epilepsy families. You have an incredible responsibility to help care for our children, and we are so grateful that you're there for us, that you support us, and you really take an interest in learning about and caring for our children. So I definitely wanted to start there because we're so grateful to have so many wonderful nurses caring for our children. I thought the context would be helpful to understand my son, Elliot. He is just about to turn 11, and he is very severely impacted by a very rare disorder called SCN8A. And you can see here that he is just working on head control. He's getting closer. He's making these inch stones of progress, and he's getting closer. He uses a stander. He goes around in a wheelchair, and has a lot of challenges, but is really this beautiful kid you can see here, who is my inspiration. But this is probably where you know us better from. This is our life. We spend a lot of time in the hospital, a lot of time being intubated, to being on BiPAPs and ventilators, getting procedures done, having studies done, and living a very medically complex life. And I think you probably see us in this space, but I wanted you to see also our lives outside of this space, to see, you know, that there's context outside of here, which I know you know, but it's good to see that. And I think you know that our lives are incredibly complex, right? This is a single day's delivery of equipment and resources and supplies at my house. That is only part of the monthly supplies. that come in, and this is what our front hall often looks like because we have so many boxes coming in. We have a large amount of equipment in our home. We have oxygen concentrators, we have nebulizers, we have a cough assist, vest, a ventilator that Elliot sleeps on. We have equipment like strollers and activities chairs and standers, and an incredible amount of medications that our children take. That is the context of our lives, that we are managing a lot, dealing with a lot. Every single one of these medications has to be reordered with a new prescription, and that are often falling, are expiring or running out. And so each of these boxes is a different thing that has to be ordered. Our lives are so filled with the complexity of having to not just care for our children, but keep them alive and get all of the supplies and resources that we need to manage their care at home. So that is a 24/7 job, right? I have been doing this for 24 hours a day for 7 days a week for 11 years. And every other disease, rare epilepsy family or DEE, developmental and epileptic encephalopathy family has to deal with the kinds of things that I do. I am here representing many, many people, and these are just some of the things that our daily life includes, which entails medications at 8 different times a day, respiratory treatments, depending on how well Elliot is doing, can be anywhere from 2 to 6 times a day. And each treatment usually takes about 45 minutes to an hour. We have to catheterize. Elliot has a vesicostomy because he cannot really empty his urine. We have a GJ tube for Elliot, and that requires care and management. You saw the ventilator, oral care, bowel regimen is very extensive, speech and vision and OT and all these different speeches. We have to keep him loose and lean. We have to clean the syringes. I know we are so envious when we're in the hospital to see how nurses have single-use syringes. That is not our life. We use them for at least a month over and over and over again, washing them several times a day. And Elliot, for example, he gets fed 24 or 22 hours a day, and gets, hydration flushes every hour of the day to keep him hydrated. And, there's monitoring for seizures, oxygen, keeping him from aspirating. This is just a part of our lives, right? That's not the loving on them and caring for them and moving them around and getting them out of the house. It's incredibly complex. And we definitely want you to know that it is so much more than seizures when it comes to the rare epilepsies. I thought maybe one way to demonstrate this is for you to understand some of the subspecialists that we see. Many of us have a dozen, at least, subspecialists that we see to manage poor sleep or respiratory challenges, trouble in, moving urine, and having UTIs, endocrinology, specialized dental clinics. GI is huge in a lot of our community, cardiology, feeding and nutrition. You can see that this list is, if you look and see all the departments in the hospital that you work in, if you're in a hospital, we see most of those. And so that really is the context in which we live our lives. And I think you get that. But I wanted to make sure that that's part of the picture that we're painting here. A couple of things, I spoke with some of the people in my community to ask, really, what do we wish that you knew? First of all, they wanted you to know that we really appreciate you. So that's where I started, and I absolutely agree. We're so grateful for the nurses that are out there doing this work and caring for our families. But we need you to also remember that caregivers are the experts. We are with our children 24 hours a day. We know them inside and out. We know everything about how they operate, what every little twist and turn and twitch means. And it is such a relief when we have nurses who say, you're the expert, I'll take my lead from you. We know you have expertise that you're bringing to the table too, and we are always happy to listen to that. But when it comes to what's happening with our children, we hope that you will understand that we know them best. Every family should be a part of the decision-making team around what happens with their child, their care and treatments and interventions. So please ask for and respect our opinions. It's really important to us. We live lives that are very disempowered that we have no control. When it comes to our children, please understand that being in control is what keeps them alive. That's how we've kept them alive. We also appreciate it when nurses respect the humanity of our children. They are not just a collection of symptoms. They are not tasks that need to be done and check boxes on. We always ask that you please keep in mind that they have feelings, they have thoughts, even if they can't express them to you. The way we treat them matters, and we need to always presume competence with our children, presume that they understand what we're saying, speak with them, and engage them in the care that you're giving. This goes back to the caregivers or the experts. Just ask us what works. Ask us what our preferences are. You know, would you rather we do bath in the morning or the evening? Would you rather, you know, what kind of diapers would you like us to use? How do you like to prepare this medication? Again, that comes back to the control, and we have ways that we do things, and usually there's a reason that we choose to do things in that way. So we always appreciate it when you ask what works and why, and how you can respect our routines. And it comes again, if you aren't sure, ask us. We love it when people respect that. We know what we're doing, and we'll ask for help when we need it. Please always understand that we are coming into your sphere as exhausted caregivers who are overwhelmed with care and life and trying to manage everything. We are probably, you know, potentially working a full-time job while we're trying to do all of this. We have other children. We don't sleep. We have depression and anxiety, and not just PTSD, but continuous traumatic stress disorder. So we may be short with you sometimes. We may come in with our lists and our notebooks full of things and look like we are, you know, overly, you know, wanting to control things. But that's where it comes from, is that, you know, our lives are really, really intense. So please give us a little grace. Help us get the referrals we need. When we are inpatient, a lot of us use that as opportunities to get referrals for doctors that we have a hard time getting in to see. Maybe our kid is missing lots of therapy while we're in the hospital. Help us get PT and OT and whoever, child life in there to help give our kids the best possible experience. If we're in the clinic, ask us what kind of things we need and help us get those things. Please recognize that trust is earned. You know, in the beginning, we may look at the meds you're about to deliver to make sure that they align with what we do at home. We may ask you questions, but once we get to know you and we start to understand how you operate and you understand how we operate, we start building that trust. And please practice your G and GJ skills. So many families I talk to say that is such a hard thing to watch people manage. So, you know, clamp, give, unclamp, you know, find your routine for that. And we appreciate that. When it comes to seizures, please always ask what our children's seizures look like. And we will tell you, we will show you videos. We will give you all the information you need to help us recognize what's going on. Please ask if we have a seizure action plan. We're happy to share it with you. We will paste it up on the wall. We will have you put it in the chart if it's not already there. And if we don't have one, maybe help us figure out how to get one. And with the doctors, please make it a priority to give medications when they are due. This is such a struggle for so many families. Medications are given at those times for a reason, and we are really, really stressed out when that doesn't happen and when we have to keep asking. So we would appreciate if you would prioritize getting the medications from pharmacy when they are due, which I know is not always easy and it's not always your fault. So, but that's so important to us. And when it comes to seizures, don't overreact and don't underreact. Follow our lead. We see this every day. We live this, we breathe this. We understand that you have protocols, but please also just take the lead from us where appropriate. I think connecting us to resources is this other really important thing. I am biased here. I'm sharing Deep Connections because this is a project that I started and run. But the idea here is that we have incredible resources for families. If you see families that are struggling to figure out how to do oral care with their kids, who don't eat by mouth, and they're struggling, they have swollen gums, and their teeth are rotting. We've got a webinar on that. If families are wanting to learn more about SUDEP, or sudden unexpected death in epilepsy, those are the kinds of things that we have here. There's other amazing things like Courageous Parents Network, other groups that have resources for our families. So it was great to educate yourself about what's out there, and then find ways of referring families to those things, so that you can support us on our journey. I think those are all the slides I had. And I just wanted to wrap up by saying, I really appreciate the opportunity to speak with you, to share my experience, some of what I hear from the community of other DEE and rare epilepsy families. And I appreciate the time that you're taking to watch this and educate yourself. And please continue to do that, to grow and learn. And reach out to us patient advocacy group leaders. You saw on that last slide, there were 45 different groups or so listed there. We are here to be resources for you. If you have a family that comes in with a disorder you don't know about, look it up, find us, reach out to us, put us in touch with the families, and we're happy to share experiences that we are learning from the wider community. So again, thank you so much, and I look forward to hearing your questions, and feel free to reach out to me anytime. Thank you so much.
Firstly, I'd like to thank the ILAE nursing section for asking me to present today, and for also organising this webinar to put the spotlight on the complex epilepsies, something that I'm incredibly passionate about. I'm delighted to tell you about what nurse-led epilepsy services are like in Australia, particularly highlighting my new role as a developmental and epileptic encephalopathy clinical nurse consultant. I've got nil disclosures. So today I'll be providing a brief overview of developmental and epileptic encephalopathies, DEEs, drawing on my experiences and expertise to shed light on the shifting problems faced by patients and their families across the lifespan. I will then focus on the role of the DEE clinical nurse consultant, a new model of care in Australia, and the nurse-led projects I have been involved in to improve patient care. As you know, Australia is on the other side of the world. And here you see a map of Australia, and I have superimposed a map of the UK to give you an appreciation of how geographically large Australia is. This in itself raises a range of other problems, like being in rural and remote areas and accessing specialist care, particularly those with complex medical needs. So epilepsy has multiple causes, and as I've mentioned, a major part of my work is working with patients with DEEs. So what is a developmental and epileptic encephalopathy? So the underlying genetic cause, so the etiology, results in developmental impairment in its own right, with the epileptiform activity further adversely affecting development as two separate but interconnected components. DEEs are the most severe group of the epilepsies, typically beginning in infancy and childhood. Mortality of the DEEs is high, with approximately 17% dying by 20 years of age. At diagnosis, families are suddenly faced with a grave prognosis, and you can only imagine how devastating this is. I now want to draw your attention to this important paper by Oliver et al. Published this year. This paper identified greater than 825 genes have a DEE. This list of monogenic epilepsy genes is publicly available and has undoubtedly changed the landscape in improving the diagnostic yield for DEEs. This is well illustrated in one of the most common of the DEEs, Dravet syndrome, with the majority due to a pathogenic variant in the sodium channel gene SCN1A. The SCN1A gene encodes the alpha subunit of the sodium channel pictured here. And you've just seen a video of a young man with Dravet syndrome with the classic crouch gait that is often progressive and affects mobility. So how common are DEEs? So a disease is considered to be rare when it affects one person per 2,000. This paper by Poke et al., led by the New Zealand group, published this year, looked at the population-based cumulative incident and point prevalence of both DEEs and intellectual disability plus epilepsy in children under 16 years. DEEs have a point prevalence of 1 in 590 children. Why is this important? So previous studies have underestimated the burden of DEEs, and having such important data can guide the medical and scientific community in improving the diagnostic and treatment journey for patient and families. So now that I've defined what a DEE is, it is also important that we understand the complexities associated with this diagnosis. DEE comorbidities and challenges shift across the lifespan. They extend beyond seizures and can impact the quality of life of the patient, parents, siblings, grandparents, caregivers, and the wider family community. I believe this will also highlight the important role of the specialised nurse in supporting family caregivers on the DEE journey. For the purposes of today's presentation, I will only highlight the more frequent comorbidities and challenges that I regularly support parents and caregivers. So I've also divided the age groups into 3 stages: infancy and early childhood, childhood and adolescence, and adulthood. So beginning with infancy and early childhood, seizures such as status epilepticus and recurrent admissions to ICU, which are harrowing for the child and family. Feeding problems. They may just stop feeding or refusing their oral anti-seizure medications. This is incredibly anxiety-provoking for parents when they cannot get their life-saving medications into their child. Sleep problems. The parents are totally sleep deprived because their child will not sleep at all. This impacts the entire family on so many levels. We know that co-sleeping is high in this group due to the risk of SUDEP, sudden unexpected death in epilepsy. So moving on to childhood and adolescent. Seizures, so the management of the frequent seizures and their impact, particularly as a child transitions to the school environment. Respite care, supporting families to seek respite to prevent burnout. And transition, addressing fears and concerns during the shift to adult care. And finally, adulthood. I want to highlight the lesser discussed challenges in the DEEs. So the psychiatric disorders, helping families understand the psychiatric aspects of the condition and to identify and address potential psychiatric disorders that may develop alongside the DEE. Aging parents, supporting the aging parent as they care for their adult child with a DEE. And I think this is particularly an issue today with technology advancing so quickly. Residential care facilities need to be equipped to provide the specialised care for individuals with complex medical and developmental needs. So now that we have a better understanding of what a DEE is and the comorbidities and challenges associated with this diagnosis, let's shift our focus to the crucial role that the specialised nurse plays in managing DEEs. So we have a focus idea of the DEE nurse sitting at the centre of the multidisciplinary team around the child or adult and the family. I am the linking person between the patient and family, the centre of expertise in epilepsy care, and the local team. So let's delve into what this multifaceted role looks like, starting with supporting the patient and family. Firstly, I provide day-to-day clinical care. I am the point of contact, and I will often start my day with receiving many emails from parents and carers from around Australia. I also offer psychosocial support. We know the burden on parents and carers is high. It is important to identify those parents at high risk of this. Additionally, proactive planning and care coordination involves communication and collaboration between various healthcare providers to address the unique needs of the patient and family. Furthermore, part of my role is to maximise the cross-sectional supports for the family. This involves advocating for the patient's needs within the community. By fulfilling these responsibilities, I strive to ensure the family receives comprehensive family-centred care. The next concept is the Centre of Expertise in Epilepsy Care, so enabling access to research and clinical trials. I connect and update families on research opportunities, clinical trials, and new therapies. This is particularly important as we move towards precision medicine. This can provide them with additional options beyond standard care. DEEs are complex and improving health literacy is another important aspect of my role, and I'll talk further later on in this presentation. Finally, supporting families and carers to remain linked with their local medical team. This is so important. I showed you at the beginning of this presentation how large Australia is, and I have contact from families from all over Australia and New Zealand. The local treating team provide ongoing care and support. This is achieved through personal and systemic advocacy, clinician education, and sharing knowledge and support in the DEE community. I now want to talk about the nurse-led projects that have led to improved access to care. And I want to draw your attention to the International Consensus on Diagnosis and Management of Dravet Syndrome. The consensus recommends fenfluramine as the second-line treatment. However, fenfluramine is not currently approved by the regulator in Australia. The Australian government has provisions to access unapproved medications through Special Access Scheme. We needed to get access to this medication for our most severe patients. This led to an initiative which had a ripple effect. So firstly, I examined the medical records of patients with Dravet syndrome and looked at the number of hospital admissions and length of stay of each patient. I ranked them in severity using this information. I calculated the basic bed day cost of an admission to a general paediatric unit over a 12-month period against the cost of the drug for a 12-month period. This data was presented to our hospital's high-cost drug committee, and I was able to demonstrate that the hospital could potentially save money if this drug was efficacious for our patients. Although the efficacy of fenfluramine has been shown to reduce seizure frequency in Dravet syndrome, I aim to demonstrate not only the reduction in seizure frequency, but also in the severity of seizures, status epilepticus, and hospital admissions. This translates into a significant reduction in the cost and burden on the healthcare system. This month marks 12 months of our patients being prescribed fenfluramine, and I'll be able to complete the next step of comparing the pre and post drug costing. This initiative has now led to many hospitals across Australia to access this drug for many of their most severe Dravet patients. So here is the seizure diary of a 3-year-old girl with Dravet syndrome who I managed to facilitate access to fenfluramine. This is her seizure diary before fenfluramine, and you can clearly see her seizure burden was high. This is her seizure diary after being prescribed fenfluramine. She's had 2 tonic-clonic seizures in 8 months, and both seizures were less than 3 minutes. Seeing this little girl walk into clinic, making developmental gains and playing is one of the most rewarding things as a nurse. So now that I've given the context to my role and the complexities of the DEEs, I want to talk to another project that I'm very passionate about, and that's building health literacy in Australia for DEEs. This is crucial for several reasons: empowerment of caregivers, medication compliance and treatment, recognition of warning signs, improved communication with healthcare providers, and coping with emotional and psychological challenges, and advocacy and access to resources. So patient support groups and advocacy organisations play a crucial role in developing and disseminating these resources. And we've leveraged the expertise and insights of individuals who have a first-hand experience with DEEs. This ensures the content is relevant, accurate, and easily understood. So here you see an example of a health passport for DEEs. The health passport is not a new concept. It promotes a patient-centered approach to medical management. And some of the benefits of the health passport for DEEs, including centralised information, emergency preparedness, medication management, improved communication and continuity of care, and also very important, clinician education. So in summary, DEEs are the most severe group of the epilepsies. Comorbidities and challenges can shift and develop throughout their life journey. The specialised DEE nurse serves as a vital link, bridging the gap in the complex DEE landscape. Nurse-led initiatives are important in improving access to treatment. And improving health literacy for DEEs in Australia can make a huge difference to patient outcomes. Finally, I want to thank Professor Ingrid Scheffer for identifying the service gap of supporting families with a DEE and giving me this opportunity to work alongside a dedicated and wonderful team. I want to thank the patient and families also that I have the privilege of working with each day, and I truly treasure each patient's journey. Thank you.
Hello. First of all, I'd like to thank the ILAE for inviting me to speak here at this webinar. My name is Nicola Openshaw-Lawrence. I'm a registered nurse and a project manager for EpiCARE. During this presentation, I'll be giving you an overview of exactly who are the European reference networks, and in particular, who is EpiCARE. Along with this, I'll be explaining to you about the development of our new working group and the workshop that we held for nurses and technicians. I would also like to identify and explain to you our future plans and how others can get involved. So the European reference networks, often referred to as ERNs, represent a pioneering approach to healthcare and medical collaboration in Europe. These networks have emerged as a beacon of hope for patients suffering from rare and complex diseases, offering a new dimension of care that transcends national borders. ERNs are designed to facilitate the exchange of knowledge, expertise and best practices by uniting healthcare professionals, researchers and institutions from various countries under a common mission, which is to improve the lives of individuals living with these challenging medical conditions. EpiCARE, which is the European Reference Network for Rare and Complex Epilepsies, is a consortium of epilepsy experts, centres and professionals who are all dedicated to transforming the landscape of rare and complex epilepsies in Europe. It's coordinated by Professor Alexis Arzimanoglu and, as you can see, has a total of 50 members with a further 15 collaborating partners. Here you can see the complex structure of EpiCARE and all the working groups that it comprises of, and this includes Working Group 20 on the bottom right of this structure, which is the working group for epilepsy nurses. Within this, we aim to highlight the invaluable role played by nurses. As we know, nurses are frontline caregivers, often the patient advocates, and the pillars of support for individuals who are living with rare and complex epilepsies. Today, we will turn our attention to these dedicated nurses within EpiCARE, and we feel that they are instrumental in the delivery of high-quality care, the dissemination of knowledge, and the provision of vital support for both patients and their families. In this presentation, I will go on to discuss the development of this working group and focus on the pivotal role you as nurses play. In late 2022, we were delighted to announce the inclusion of the new working group within EpiCARE. It's chaired by myself, and this programme was established to address crucial aspects of epilepsy care, particularly as it relates to the role of nurses and technicians in epilepsy departments. The programme makes a significant step forward in our mission to provide comprehensive care for individuals living with rare and complex epilepsies. One of the first actions taken by this programme was the launch of a survey in December 2022. This survey was open for approximately 2 months and aimed to accomplish several important goals. It sought to ascertain the scope of nurses and technicians' roles in epilepsy departments, recognising their vital contribution of these healthcare professionals. Secondly, it aimed to understand the level of training available in the field of epilepsy nursing and how this differs per country. Additionally, the survey aimed to gauge the level of interest in people becoming members of our working group, and also whether they'd be interested in attending a one-day workshop, which we plan to hold in 2023. In May 2023, we welcomed 66 nurses and EEG technicians to Utrecht to attend the one-day workshop on best practices in epilepsy monitoring units. There was a total of 9 presentations given by experts who were EpiCARE members, and these covered a wide range of subjects, including how to organise an epilepsy monitoring unit, extended EEG arrays, and behavioural testing during and after seizures. A key component of the day was the breakout sessions, which allowed for free-flowing discussion among the attendees, and we hope that this would guide our future plans for the working group, as well as identify areas that we could focus upon. During the breakout sessions of the workshop, each group had these statements provided to them, As you can see, these 7 statements centre around several key areas of controversy and concern, with the hope that the future work of this group can be guided by the discussions and the findings from these. This will ultimately enhance the quality of care for individuals with complex and rare epilepsies and guide our nursing group. The discussions unveiled several crucial insights and areas of concern. The group acknowledged the existence of significant controversies surrounding the recent developments in epilepsy monitoring units. These included the role of home monitoring, the utilisation of seizure detection devices, and whether relatives should attend in-hospital monitoring for individuals with complex or rare epilepsies. A consensus was also felt towards the widespread recognition for the need for standardisation of protocols. And this call for standardisation would allow nurses to give consistent and high-quality care, allowing for it to be uniformed across centres. They observed that there was many variances in practices across epilepsy monitoring units, and that this differed from country to country. The group felt that it would be good if we could have an international exchange among the nurses, allowing for visits to be 1 to 2 weeks to other centres in other countries, and this would allow them to share an understanding of best practices, how they work, and ultimately contribute to the more uniform and effective care of rare and complex patients by the nursing staff. A critical issue was noted in the scarcity of professionally trained EEG technicians. Even countries with established programmes were still struggling because of the shortage of newcomers. This was a significant hurdle and one that had an effect on all, especially the nurses, and this was felt that we could maybe start to address the workforce gap and deal with this as an utmost important task. Overall, it was noted that the discussions held at this workshop highlighted the need for collaboration, standardisation and innovation within the nurses to enhance the care provided to individuals with rare and complex epilepsies throughout many countries. Following the Working Group 20 workshop, we've been able to form important initiatives and actions which are aimed at advancing the care and treatment of individuals with the rare and complex epilepsy and the role that nurses play in this. We intend to create a comprehensive membership list of our working group, allowing us to harness the collective expertise of our members and improve the quality of care provided. We will develop special interest groups which offer a unique opportunity to focus on specific areas of epilepsy care and the role that nurses can play. We are going to be transparent and share our knowledge, which is central to our mission. We're committed to publishing and disseminating the results and finding of all our ongoing work and special interest groups, this ensuring our collective wisdom benefits the broader epilepsy care community and all our nursing colleagues. We've recognised that further workshops and educational opportunities are vital for continuous professional development of nurses caring for these patients with rare and complex epilepsies, and we plan to continue to organise such events to empower our nursing members with the latest knowledge and skills. Collaboration is at the core of our success. We will work closely with the International League Against Epilepsy Nursing Section to ensure that we synergise our efforts and align our objectives, further strengthen the impact of our initiatives. In conclusion, these initiatives represent our commitment to excellence in rare, complex epilepsy care and the role that nurses can play. We believe that by working together, sharing knowledge and collaborating with relevant partners, we can make a substantial difference in the lives of those affected by these challenging conditions. Thank you very much for taking the time for listening to me. I do hope that you found this interesting. I would also like to thank once again the ILAE Nursing Section for inviting me to give you this talk. I would like to acknowledge the people here on this slide who helped make Working Group 20 possible. Thank you very much.
And Melissa, you may want to remind everybody that if you have questions, please put them in the question box on your Zoom, and we will get to them all if we can. I'll start by asking Nicola, there was a question here of what are some differences in EMUs in the European countries? I don't know if you found that through your survey or some of your work with EpiCARE, But if you could please address that question, and then certainly if anyone else can add to it, do so.
Yes, so it's definitely a topic that we're going to be focusing on within our group, and obviously learning from each other. But I think some of the differences that we saw and that were discussed at the workshop were differences such as the actual extent of the role of the nurses. This changes very much throughout the countries, and how much of a role that they can play. So we know that in the UK you get nursing practitioners that can epilepsy nursing practitioners that can prescribe, that have a large role in terms of anti-seizure medication and altering for side effects and things like that. And then there's countries that in Europe that don't allow nurses to prescribe. So that role then it kind of not lessens, because of course they've still got other options, but it takes away an element that they could help the family with. So that was one of the significant ones that we found. And just the educational opportunities that are available for the nurses very much vary between countries. And again, this is something we really want to focus on within our working group, to try and see where these gaps are, and is there a consensus that they want an overarching kind of educational plan for European epilepsy nurses, or whether it's, like we said, the exchange program. So you're learning from each other the best practices that you can then take back to your country. So they were some of the differences that we've seen.
And I want to build on that. Do you expect that this group too will come up with some best practices in terms of supporting individuals with the rare and complex epilepsies as a sub-activity to what you're doing in a general sense?
Definitely, this is definitely a goal of ours. So with our special interest groups, best practices and standardization is definitely something that we're going to be looking at. And as we said, we're very keen to help people to disseminate their knowledge as well. So it's all also well and good, learning from each other in a group, but we want to be able to disseminate that wider. So yes, definitely, that's a really key mission for us. Yes.
Well, I think we'll all look forward to that. And, I think we all can learn from each other. And it's an area, as we've heard from Gabby, that we all probably need to continue to do a better job in supporting our families, listening to them, especially for this population, so that they get the best experience possible and everyone gets the clinical data that they need. I now have a question for Bri. Do patients in Australia have trouble getting medications that are not readily available in relationship, I think, to cost, or just as you had identified some blockades, barriers that may occur because of their availability?
So not generally. I guess the example that I gave was fenfluramine, which, as I said, is not approved by our regulators. So the example also that I gave is how I got access to families that couldn't privately fund it. So we got it through the hospital system. But generally in Australia, medications, anti-seizure medications are readily available. It's just that this particular drug hasn't been approved yet.
And Gabby, I don't know if you can add to that as a parent advocate. Are you hearing struggles out there for families to try to get some of these needed medications? Or even, as was mentioned, participating in some of the clinical trials that might be available?
Yeah, no, thank you so much, Nancy. I mean, absolutely. There are many, many families that are looking for other options, and many families, DEE families who have exhausted the medications that exist out there, right? So they have tried everything that is on the market that is potentially indicated for something like what they have. Most of us have no drugs that are actually indicated for our disorders. And so we are trying, technically everything is, I guess, because it hasn't really been tried in our disorders. And absolutely, there are challenges getting those medications, and of us having to fight for approvals of doctors and nurses having to go to bat for us and spend hours on the phone making arguments. I mean, the kind of work that Brialie's doing is amazing to show that there's true impact here to be had for making these treatments available. And I'll quickly just say that I think one of the biggest challenges is that in terms of clinical trials, there aren't clinical trials for most of our families, right? So, Dravet, TSC, LGS, those are the 3 large DEEs where there are lots of clinical trials that are underway and available. But for the smaller disorders like SCN8A, there are very limited opportunities to engage in clinical trials. And so, we advocate for like basket trials or, the kinds of things so that we can really see, instead of doing it one indication at a time, like with Epidiolex, right? You start in one disorder and that takes 3 or 4 years. Then you go to another disorder and it takes another 3 or 4 years. So in the future, what we'd love to see is more work being done, seeing the DEEs as a cohesive community, because the truth is that we have very similar seizures, very similar comorbidities, unless it's something that is being targeted to a specific genetic etiology. There's a lot to be said for the power of working with the DEEs as a community, as a cohort.
Thank you. Someone who used to do a lot of clinical trials in this area, that's a really novel approach. I know that not only would you have to deal with that in the US, but then, of course, ex-US. Have you made any progress globally to get this as an accepted practice for clinical trials?
Well, I'm doing some work around that. It's still definitely a work in progress. And I think making that case to regulators is something that has to be done. There has to be, there is some groundwork that's being laid. There's one company that I know is actually just finished recruiting for a cross DEE in a clinical trial. So they did it, you wouldn't be the first step to do it. If somebody was looking to do it, it has been done. And frankly, if you're doing an LGS trial, you are doing a cross DE trial, right? Because LGS is not a actual diagnosis of an etiology, right? It is a syndrome that appears secondary to another etiology, right? So we have lots of examples of cross DE trials that are already being done, but we just have to continue to make that case. And this project that I'm working on called the Inchstone Project is doing that work right now. We just finished a DEE-wide survey with around 270 caregivers from more than 20 different DEEs involved. And through this, we're hoping that we can show that this is a cohesive community with similar challenges, similar needs, similar kind of need to kind of see these drugs come in for more than just one disorder at a time.
Oh, Patty, I know you're not on camera, but all of what we've heard today from our 3 distinguished speakers has been very enlightening. What resources exist in ILAE for us all to stay connected and learn more about this topic to better serve the individuals that we serve, the patients, the caregivers, et cetera?
Yeah, thanks for asking, Nancy. So from the nursing section is still young. And all of the different regions around the world have been looking at what the needs are of nurses in their region. And what's really exciting is coming up in 2024, we're going to be some nursing symposiums being seen in, I think it's 4 different regions. So for example, in Latin America, there'll be a nursing symposium in Spanish, and that will be in June. In Europe and Rome, the European Congress is going to include, hopefully, a nursing program in September. In New Delhi, as part of Asia and Oceania, it's in November. And then in October, there's going to be one for North America in Montreal. So I don't have the actual agendas of each one, but please stay tuned by going to the ILAE nursing section, and you can see that, or the Congress section. And we're also planning a series of webinars over the coming year in 3 different languages. So we'll have English, French, and Spanish ones. So request ideas of things that you want. You can send us an email at whatever it is, the ilenurses@gmail.com. But stay tuned as well, because we'll be kind of putting out all of the topics that are coming soon. And lastly, we're trying to plan on updating we're not updating, but expanding the website for the ILE nursing section to be able to more readily link to where things are on other parts of ILE, but also to other organizations, that all these rare epilepsies and other groups, where you can more easily find the information for yourself as nurses, but also for patients and families.
Well, and I know this webinar is being recorded and will be posted for later viewing by anyone who attended today, but for colleagues maybe who were not able to attend. Is that correct?
Yes, it will be on the ILAE's YouTube channel. So just go to YouTube and put in International League Against Epilepsy.
Yeah, and I know there's other webinars being done across the organization, maybe not totally focused for the role of nurses, but certainly addressing this topic with timely information, correct?
Yes, and if you actually look in the, oh, we can't put that up. Yeah, so there's the actual, Annabelle just put in a link for the YouTube channel right there that you can see all of those.
Very good. I think we have time if someone from the audience has one more question, or one of our panelists have a question for each other before we close the session out.
I actually might ask a question, Nancy. I was just, I've got one question for Brialie. I was thinking, what do you think, in your presentation you discussed about transition and going from kind of a pediatric setting to an adult setting, and what do you think is the biggest challenge for families transitioning into an adult service?
That's a very good question, Melissa, because I think I'm lucky in the aspect that I work from pediatrics across to adults, because the neurologist that I work with, Professor Ingrid Scheffer, cares for both. But I think my, I guess, 2 concerns that I have for families is, one is the aging parent. It is really difficult. They have cared for their child 24/7 for years and years and years. And that fear of being able to plan for the future of their child is, and also meeting new people. You know, you're in a pediatric setting, and that is completely different to what the adult setting looks like. But for DEEs, the care hasn't changed because the parent is going with them. So it's different to transition of someone who doesn't have a DEE, that I shouldn't say just, but has epilepsy as a single condition. So I think that's really complex. But the thing that I'm also, and I briefly mentioned in my talk, but I probably didn't expand on, is we're moving so fast with technology, and the aging parent isn't keeping up with that. Simple things like appointments being sent as a text and them having to reply. If they don't have a smartphone, and I spend a lot of time with parents just ringing me, more elderly parents with adult children with a DEE, just asking me to talk through different processes. So the transition to the adult care has happened, but there's also the secondary issue of technology advances and how hospitals are moving completely to electronic systems and them trying to keep up. But I think supporting families from transitioning into pediatric to adult care is something that needs to be worked on. I don't know if it's just Australia or if this is a common issue around the world, but it is really complex, and I think we really do need to spend more time on working through a model of care of how best to support families.
Thank you so much. It's a issue we're addressing globally. And I think you brought up a lot of really good points. Melissa, I think we are at our hour here. I know you have a few comments in closing for the group.
I'd like to just thank everyone for attending, and especially all of our guest speakers. You all spoke very brilliantly, and I hope to everyone gained a lot of information about what you guys have provided today. And so for those that are that want to join the nursing section, you want to share it with your fellow friends, the website's been up there on the screen for a little bit. And we are also then looking at thanking everyone, and stay tuned for sessions next year. And everyone that has any ideas or want to hear more about certain things, please email the ILE-nurses@gmail.com and we'll try and incorporate that for next year. Thank you all for attending and all the hard work.